Super, thank you. So drawing back then to the evaluation findings, I'm going to try my best to build on what Kerry's already said about some of the findings from the health visits pilot, include alongside that what we understand from the GP and kind of draw it all together. I apologise if it's a bit of duplication of what Kerry said or if it's a bit convoluted, but that's why it's great that we've got kind of that Q&A at the end so I can just clarify anything that perhaps doesn't sit well, but my aim is to identify where there were similarities across the settings and the pilots and where there might have been key differences. So for Public Health Wales, as the evaluators of these, our objectives across all of the pilots, so the REACH pilot in Lancashire, the GP pilot in North Wales and the health visits pilot were all essentially the same. So it was about feasibility, does it work, can they do it? And how long does it take to implement and what does that mean? Acceptability, how happy are people to do it? And then something around what we can learn. So admittedly, these are quite small-scale pilots. They're local initiatives. They are limited in scope and they come with numerous limitations in terms of the data that we can collect. But we really wanted to make sure we use these opportunities to gain some understanding about what would we do if we were evaluating this over a larger scale or over longer term. What data can we access that we might be able to use and what does it tell us already to suggest that that's the kind of data we might want to look at in future if we're evaluating bigger projects like this. So just really briefly, the evaluation framework consisted of taking process measures in terms of how many were delivered over what time scale, how many people chose not to, things like that. Service user feedback was completed. So in the GP setting across both England and Wales, patients were given a short anonymous feedback questionnaire in the form of a postcard at the end of their appointment, and they ticked a few answers to how they felt about the experience and posted it in secure kind of survey collection boxes. And in health visiting, it was part of the outcomes questionnaire that they answered at 6 months. So there were some additional questions tagged onto that asked about their kind of views of the experience of being asked and responding to those questions. We also had quite detailed either semi-structured interviews or focus groups with practitioners that were involved. So it involved all of the health visitors from that setting and available GPs and advanced nurse practitioners that were able to feed into that process, as well as practice managers and administrative staff or reception staff could also share their experiences of delivery. So the headline findings, I suppose. The figures that I present here draw together feedback from service users across all of the pilots. So we're looking at close to 700 people here now that have been through ACE Enquiry by one of these models. And I think it's fair to say that they're quite overwhelmingly positive. So 88% of service users agreed that it was acceptable to be asked about ACEs in their health setting, so GP or health visiting. 82% felt it was important for the health practitioners to understand their experiences during childhood. And the one that's really interesting for me is that 58% overall said that the help and support they received was improved. So like Kerry said, in health visiting, this is across all of the pilots. We see over half of people that felt that there was a benefit from that, some utility in that process. Now, it might be easy to think that that's only around half, but when we think about the fact that a large proportion of people don't even have ACEs, so we wouldn't necessarily expect them to experience a benefit from the process. And also a lot of people, this was kind of highlighted to me by a GP who said, I don't think that patient would know that it was meaningful at that point. They might only know it's meaningful if in the future it becomes a relevant part of a discussion that we have, or if they go away and reflect and feel differently about it. So the fact that at the time, immediately after the process, as many as 58% people felt that the help and support they received was improved, I think is a really important finding that supports this idea that there is some benefit. For me as well, I think it's the idea that this creates a really unique opportunity. So overall, across the pilots, 56% of people said this was the first time they told a health practitioner about their experiences. In general practice, we can probably assume that these people have engaged with health services before. Certainly in health visiting, they would have engaged with midwifery. But this inquiry pilot was the first time they'd had that opportunity. And I think that's a really important thing for us to remember. So just to kind of talk a little bit about the different settings. The reason that I put this up is mainly to emphasise that there is importance in the detail. So for reasons that are kind of a bit beyond the scope of the time that I have here, Practice D in particular had some challenges in delivering the agreed model within North Wales. And it's interesting that in their deviations from the model that was agreed, we see that people were less kind of convinced by the support that they received as a result of that. Whereas obviously we compare all of the findings from GP to health visiting, and we see that generally people were a bit more convinced that it was beneficial for them. And health visiting, as we know, was a model which was delivered in a more standardised way to everybody. It's a word of caution, I suppose, that small differences in delivery can seem to have some differences in the way that people feel about this. There's always a question about, are people just happy because they didn't have any ACEs? So I think this one is quite interesting because the patient feedback surveys were anonymous, we couldn't tie them to people's ACE score that was derived from their ACE inquiry. But what we did do was include a question at the end that said, when you were asked about ACEs, did you disclose any? Yes, no. So from that, we just simply knew whether people had had ACEs, yes or no. And among those with no ACEs and ACEs, we see, really similar results in terms of their views about the acceptability, importance of ACE inquiry. The only one of those differences that's significant, incidentally, is the middle one, but only just. So marginally, people with no ACEs reported more positively there. The one that's most interesting for me, I think, is about the help and support improved, just because it suggests that there's some universal benefit. So even those that don't have ACEs, or I suppose importantly are not willing to disclose ACEs in that context, thought there was a benefit. So reasonably those that didn't feel comfortable disclosing if they had ACEs even perceived there to be some benefit from that process. And I think for me, one of the key things from a research perspective moving forward is understanding what the mechanism for that is. So is it to do with this improved relationship? Is it to do with this open trust? But there's obviously something happening there, even for those that don't have experiences of adversity. Within service user feedback, we provided space for people to provide any general comments that they had. I think generally we don't expect these to be particularly well used, but across all of the pilots we had about 32 individuals that took the time to provide some additional comments. And when we looked at the general themes of these, they were largely broken down into three things. So there were people that reflected positively on their experiences of ACE inquiry, so said things like they thought it was useful, they thought it was valuable. They also seem to understand the wider implications, so why it might be a positive move generally for people to understand the links between early childhood and later life. And then we had the people that expressed some concerns, shall we say, about how it was delivered. The one at the top is a personal favourite of mine. There was more in that I couldn't repeat on a slide, but it was quite amusing that they were so concerned about the burden on their GP. I thought that was wonderful. But in a serious note, there were some concerns about the kind of privacy of being asked in this setting, and some suggestion that perhaps it could be sent out in post alternative to being completed in the GP practice. The other one was around kind of extending what was already included. So there's a suggestion, this is interestingly a common one that we hear in academia and practice all the time around the definitions of sort of age differences in some of the ACE questions. And then also they felt that perhaps there should be a specific question about their experiences now and how it was impacting them. To be totally honest, this does raise a bit of a caution for me, in that we would hope that that was happening anyway. So if the patient felt the need to suggest it should be happening, perhaps there's some question mark around the fidelity to the wider discussion that's happening there. So before I reflect in a bit more detail on what practitioners actually said during feedback, I thought it was really important for me to describe some of the challenges that were encountered in getting to the point of delivery. I think it's important to start this by saying everybody got there. So all the pilots, all the services got round to delivering ACE inquiry. But there were some considerable challenges that I think it's really useful for us to learn from. Many of these won't be a surprise to you, I imagine, because they might be challenges that you encounter when implementing any kind of change. The first was about availability for training. So not such a concern in the health visiting, but certainly in the GP pilots, getting all the right people together at the right time, taking them away from clinical hours to support them through this process, particularly when the practices had a preference for doing that all together, so having it collective rather than in bits and pieces. And then also kind of supporting ongoing training needs. So perhaps for new members of staff that came in during the pilot and some of the challenges associated with that. Engagement in training was a particular issue. So thinking specifically about the pilot in Lancashire, all of the staff were involved in training, but reception and admin staff in particular found it really hard to understand why they had to be there and why it was relevant to them. So there was kind of a lot of pushback really in, was that the best use of their time, and how did they fit as part of this model? And that was a key challenge that had to be overcome in getting them engaged and getting their buy-in. I think it's really interesting to contrast what happened in GP and what happened in the health visiting, in that, as Kerry described for health visitors, although they were reluctant, they were all required to take part, and their reluctance was soon replaced by positive reinforcing experiences. In the GP pilots, it wasn't a requirement for them to take part, and across all of the sites and surgeries that were involved, only a small selection of practitioners at each site actually took part. And this caused quite considerable concerns. Firstly, that it was a pilot of the willing, so well, it works pretty well because they're the people that wanted to do it anyway. But also there was a feeling that practitioners that were doing it would have a better time of it if everybody was doing it, because if they were running behind, people were looking at them saying, well, their clinic's running behind, but their colleagues weren't running behind, but they weren't doing it, and there was no kind of shared responsibility for that initial burden. In line with that, there was a particular senior person in the Lancashire pilot who was a partner who wasn't keen and was quite vocal about that, and there were considerable implications of that for buy-in across the rest of the practice, as you might expect. Because of these nuances of not every practitioner delivering it, there were increased challenges for this process of how we get patients engaged in the first place. So for reception staff, that meant that it wasn't just a simple matter of handing out questionnaires to people that were eligible. It was understanding, right, this doctor's in this session now, are they doing it? And then the next day, that doctor might be in but not doing it. So there was a real complexity in kind of managing that from their side. And in a lot of cases, the practice managers would describe that, yes, there isn't an increased burden for our clinicians, but there's quite an increased burden for our reception staff in dealing with this need. In the Anglesey GP pilots, they all operated electronic booking-in systems. And compared to Lancashire, where they didn't, their job of handing out ACE questionnaires became significantly more difficult. Some practices decided to turn it off, others, reception staff, had to try and intercept people afterwards. So there were some real concerns around that start of the patient pathway and how we engage in ACE Enquiry at that stage. One of the key challenges for implementation was about, I've described it there as resilience in the system for lateness, but essentially the fact that the timings would work if people were always on time for their appointments, and largely people were not on time for their appointments. Some clinicians were happy to have them complete the ACE questionnaire in the consultation room. They thought it was important, so they allowed them more time to do that. Others weren't. So there was a potential there for a cut-off of, I'm sorry, but you just don't have the time to complete that. And there were plenty of descriptions of times when patients came into to see the doctor or the nurse and were still trying to complete this ACE questionnaire. So it wasn't really given the time and space for them to reflect on it as they might want to. I think it's fair to say that in all of the pilots, and this extends to the health visiting work and the GPs, there was what I would describe as insufficient run-in time. So I think for almost all of them, they didn't start when they first thought they would start, and there was always something that meant that more time was required. In some cases, for health visiting, it was simply having the time to add unique identifiers to questionnaires, things like this that meant that timescales were quite often too ambitious for the delivery. And data management and abstraction was a particular challenge. Now, I understand that inherently part of this challenge is to do with the fact that it was being evaluated, and they had to develop mechanisms for sharing that data with Public Health Wales. But I don't know if this would surprise any of you, but I was quite staggered to discover that one of the GP practices in Wales only had paper records, which presented, as you can, some wide eyes over there, presented some real challenges for trying to understand some of the impacts of ACE Enquiry. The health visitors one, although paper was a walk in the park in comparison, I have to say. And adherence to agreed models of delivery. So I alluded to the fact that in one of the practices, it wasn't necessarily delivered as intended. There are two challenges here, really, I suppose. One is that if they're given the flexibility, they can deliver as and when they like, and there's some inferences around the universality, and we talked in the health visiting about how important it was for engagement of service users, that they felt this was happening to everyone. And obviously that was a challenge when delivery wasn't necessarily as was intended. The other thing, selfishly, from an evaluation perspective, is it makes it very, very difficult. We have very limited ways of understanding fidelity to a model of delivery. So we were reliant on practitioners telling us afterwards if they'd done what they said they were going to do and how that went. And to the best of our knowledge, what we have at the end of it is some suggestion that some people veered off course a little bit, and there could be quite considerable implications of that, as we saw, for patient views about that experience. I just wanted to share this with you just as an example of how things might have changed. So this is from the REACH Pathfinder in Lancashire, and it just shows the number of inquiries and the number of decliners that were delivered over the period of the pilot project. In August, I think everybody was on holiday, so there were 8 inquiries delivered over that month. So we see that it's not a consistent pattern of delivery, and there were lots of kind of external pressures that influenced that. I think also there was a time in there when they took on, the practice took on a cohort of students from a local university. So there were considerable kind of unforeseen challenges that had an impact on how it was delivered. Thinking then about the process of delivery, so as I mentioned, we did focus groups and structured interviews with practitioners, and these are the reflections that I've tried to draw kind of thematically from 33 practitioners that took part in that process across all of the pilots. So generally speaking, the structured tool in the form of the ACE questions was really welcomed for reducing the cognitive and emotional burden on service users. They thought it was a quick and efficient way of gathering information that arguably, yes, they might kind of develop organically over time, but as Kerry said, this presented all that information to them as soon as possible in the patient pathway. They also felt that it really improved the control that the service user had, so it was entirely up to them what they ticked and what they didn't. They could disclose some of the ACEs if they had them, they could choose not to disclose certain ones that they might have had. And it was reflected to me by a health visitor that whilst mothers were happy to tick these things on a sheet, actually when it came to vocalising them, some mothers really struggled, and they didn't necessarily even have the words to describe those experiences. So having that tool was a really supportive way of allowing them to disclose what they chose to without having to divulge detail if they didn't want to. For the most part, health visitors were really keen to use the prompts that were provided by the trainer and the facilitator. That wasn't so commonly used by the GPs, I have to say. They were more inclined to kind of incorporate it into the types of patter that they already used with their patients. But generally, conversations were structured around wider awareness raising and understanding the impacts. And as Kerry mentioned in health visiting, related to that idea about intergenerational transmission. In terms of impacts on practice, obviously we've mentioned in health visiting, but it applied to GPs, that there was no overall increase in service demand. So all these initial concerns weren't really realised during these pilots. Largely, there were very few impacts on individual consultation times. So we mentioned that in relation to health visitors, but it applies again, like I said, in GPs. There was a general understanding that this can happen any time in clinical practice, but I have to say there were quite different views as to how acceptable that was. So while some people felt that, you know, it's no different to someone presenting with suicidal thoughts and me having to divert my usual kind of consultation style with that individual, others were particularly concerned that when they felt rushed for time and surgeries were overrunning, that their delivery of ACE Enquiry might have been a bit tokenistic. So almost this sinking feeling that I don't really have enough time to do this, and what implications does that have for my patient? When delivered by agreed models, and again this is the important bit, no service user requested onward referral or support, or kind of booked a follow-up appointment to continue that discussion. So whilst we know that some discussions were continued over subsequent health visitors appointments, in GPs there was no evidence that anyone needed anything in addition to that initial conversation. Very much the opinion of practitioners was that patients simply said, oh, I've already dealt with that, you know, it's useful to talk about, but I don't need any additional support at this time. The one that I thought was really interesting was a health visit who mentioned that a mother had indicated that she'd already received help and support earlier in her life to deal with a certain issue. But but actually reflecting on this conversation now she was a parent herself made her realise that maybe that support wasn't appropriate at the time. So she'd gone away thinking that she might want to revisit that. So not requiring anything different from the health visitor, but presenting the opportunity to reflect on perhaps support that she'd had previously. In terms of the benefits of ACE Enquiry, well, across GPs, as Kerry described in health visitors, there was this real sense that it improved the relationship between the health practitioner and the service user. So they described increases in trust, increases in empathy. One of the GPs actually described an increased tolerance for patients' bad behaviour, so getting impatient at the reception desk or phoning day in, day out. So they felt that perhaps they had a different understanding about what that person's needs were and why they were acting that way. Generally, they thought it allowed them to better understand their service users. So this idea that actually it is quite novel information, we don't already know this, and with this understanding I have a different kind of view as to the types of care that I could provide. And as Kerry mentioned, it really did challenge their assumptions. So there were quite a lot of times in the GP where they would say, I really didn't think that that was the case. Also, that the reverse of that, there were people that, they were really astounded and impressed by the level of resilience they showed. I think the interesting thing as well is that they kind of applied that beyond their own role as a clinician. So they would say, well, you can't unknow it once you know it, and actually it's changed my view of my relationships in some of my personal relationships with family and friends as well. It did serve to highlight particular at-risk groups. So one of the GP practices in particular was really surprised that a lot of their patients with ACEs were in the 18 to 25 age category, and a lot of those patients had already consulted for mental health problems, but their experiences of adversity hadn't been discussed previously. And then there was this tentative suggestion, again from practitioner feedback, that there might be some change in the attitudes and behaviours of service users. So mothers thinking differently about how they wanted to parent their children, and patients kind of changing their help-seeking behaviour, so looking for a type of conversation with their health practitioner rather than looking for an additional test or kind of some resolution to a particular health complaint. Understanding the potential harms. I thought this was important for me to include in here. So the GPs, obviously unlike the health visitors that have that continued relationship, were really quite concerned about the fact that someone leaves and then we don't really know what happens to them beyond that point. So obviously whilst it's important to say that there was no evidence of any harm, it was just a concern for them that, well, how would we know if there was? They were quite clear that, this idea of a therapeutic benefit, intuitively, it's nice, it makes sense, but how would we ever know? We can judge their body language at the time, but we really don't know whether patients are taking some kind of benefit from that conversation. And obviously they were concerned about the lack of follow-up, that if patients chose not to engage, really there was very little they could do in that context. In Lancashire, I think this was in the initial pilot, there was some concern about the prospect of some kind of litigation. So what happens if we've asked and we identified ACEs and then we do nothing and then something happens and someone says, well, you knew that, why didn't you do something? Alongside that, they had concerns around how this information could potentially be sort of in their mind abused almost. So in terms of life insurers, for example, what would they say if they consulted a record and that was there? What does that mean for how we capture that information and how it's shared? And I think this one is really crucial. There was actually a member of staff in the Lancashire pilot who said themselves that they had ACEs and therefore they didn't feel that they were in a position to ask those questions of their patients and have that conversation. So I think we can't underestimate either the potential for harm among our clinicians as well as our service users. I wanted to reflect a little bit more on where the key differences I think lie between the pilots in these two settings. So as I think we've already described, in general practice participation was voluntary. And with that came some associated challenges around who was delivering what and when, logistical issues that affected admin and reception staff in particular. Versus the kind of sense of whole system or whole service engagement, where health visitors were all sort of in it together, and although they had their concerns, they got through those concerns and had positive experiences of delivery. More specific eligibility criteria were applied in all of the GP pilots, and obviously with that came an added kind of level of complexity, and is quite unlike more of the universal approach that was delivered in health visiting. That being said, I suppose the reverse of that is that although the delivery in the GPs was flexible and that they could avoid days when there was challenges to their capacity, the standardised deliveries we heard from Kerry and the health visitors also wasn't necessarily what they wanted. They wanted a bit more flexibility around when to ask and using their professional judgment in that respect. So we've kind of got the flip side of that that's also presenting its own challenges. And again, as I just referenced, the idea of no clear follow-up mechanism currently within the GP pilots, compared to the reassurance that health visitors seem to have when delivering this, that there was always going to be opportunities to revisit this, and they would continue to see those service users and could pick up on any ongoing challenges. I wanted to share these with you, again, to reiterate that we're talking about really small samples. So these are really tentative kind of suggestions as to some of the types of impact that we might be able to demonstrate. So on the far side, we have those that had 0 or 1 ACE. This is from the Lancashire GP study. And on the other side, nearer to me, we have those with 2 or more ACEs. And this looks at the change in attendance patterns. So it compared the number of times that they attended for a face-to-face appointment in the 3 months prior to ACE Enquiry, and the number of times they attended in the 3 months after ACE Enquiry. Obviously, for both groups, it's about 40% or so of people that attended less in that time period. But we also have a significant proportion of people that are attending more. And whilst the attendance patterns did change for those with the greater number of ACEs, overall there was no difference in the level of change for both groups of people. What is slightly more kind of persuasive, I suppose, is that we looked at medication use over the same time period, so the number of repeat prescriptions that were written for patients in the 3 months before and 3 months after. And potentially it looks like there's a bigger reduction in those with a high number of ACEs. Although I suppose the big caveat for that is, although we vaguely know why people were presenting at the time, we are expecting that at the time of presentation people may have a particular health issue that would require some kind of medical intervention. So what we can say about that meaningfully is a bit limited. But there is at least some suggestion that maybe we could see, if we were able to look through larger and kind of longer pilot studies, maybe a reduction in prescribing might be a key element for us to consider. In terms of the health visiting, so I mentioned the 6-month outcome questionnaire that was used with mothers. So we had those that received ACE Enquiry early and those that received ACE Enquiry later. So potentially didn't have the same opportunity to reflect on that and for that to shape their relationship with the health visit in those that first short period. 60% of those in the early inquiry group, when asked at 6 months, said that they felt that they and their family got involved with the local community, compared to only 36% of those in the 6-month group. So again, potentially some suggestion that it might be worth looking at whether in this sample, or this type of sample, the experience of ACE Enquiry has some impact on how people are willing to engage with other people, other services, their confidence or their knowledge about how to do so. So what's happening next for us? Well, just to describe, I have to say I don't know precisely where this agenda is moving in England after the Lancashire pilot, and there may be colleagues in the room that are better able to reflect on that, but talking about Wales specifically, Welsh Government have now funded a pilot to extend the health visits work. So they're taking the model that was used in Anglesey, and it's being run over other areas in South Wales and Mid Wales. It's a step-wedge implementation, which for anyone that has a ridiculous amount of time and wants to be bored by it, I can explain to you, but basically means they're all starting at different times, essentially. And the first site started implementing on the 1st of March. So if all goes to plan, we should hopefully have a sample of about 3,500, maybe 4,000 families that will have been through ACE Enquiry across different parts of Wales. Recognising obviously that our findings from Anglesey are really good proof of concept, but it's quite a unique population, so we want to look a bit further across the rest of Wales where we have different levels of ethnic diversity, different demographics, etc. So here the evaluation framework we're using again looks at feasibility and acceptability, but the larger pilot supported by Welsh Government allows us to look much more at the data that the services hold and use some of that data to look at potential differences for those that do and don't have ACE Enquiry. And try and understand what predictive power knowing about ACEs might have. So does it explain some of the things that we already collect? Does it explain those better than the information that we already have? and thinking about maternal and child outcomes such as breastfeeding, child development milestones, etc. Work is also ongoing to extend this idea of ACE Enquiry into other kind of targeted population groups. So I have been working with the All Wales Cystic Fibrosis Network. They're asking ACE questions within their yearly psychological assessments that take place with a clinical psychologist. And there's some kind of seeds being planted, this is in its very early stages, but work that looks at the feasibility of ACE Enquiry or its acceptability with particular groups of patients within general practice, so those that may have fibromyalgia or chronic pain. And there is the ambition and a bit of a drive to potentially in the next year or so look to revisit the Anglesey cohort and think about some of the more longer term sort of evaluation aspects that could be considered there. So just to kind of finish off from me before we can hear a bit more from you, the conclusions of our learning so far is that there's obviously initial support for the acceptability of ACE Enquiry in healthcare settings among both practitioners and service users. And I think that's important that we're looking at, people are happy to ask, but people are happy to answer. And that's quite a strong finding throughout all of the pilots. There's a real suggestion that it improves the quality of their relationship somehow. So we don't necessarily understand the exact mechanisms for this, but we can see that there's this real sense that quite universally there's a benefit for people from being involved in this process. There is clear support for the feasibility of ACE Enquiry and health visiting pathway, although as we said there's more calls for maybe slightly flexible or more flexible approach in that respect. However, it does seem to be the case that the GP setting presents some more inherent challenges for the delivery of this type of model. And actually, from the ones that I've described, I think it'll be apparent that this hasn't currently, as it stands, been delivered kind of at scale across whole practices at that kind of level. So there is continued questions there about the possibility and the feasibility of that. What we do know is that experience in adversity in childhood is related to greater levels of healthcare need. So we kind of deduced that from national surveys and some of the prevalence work, but that finding is reiterated in these samples. And then because of that, it makes it really interesting that there is some tentative suggestion of modest changes, be that in service use behaviour or outcomes for health and well-being. And obviously this, as researchers always tell you, warrants further study. So overall, I suppose the key headline message from me is that further research and evaluation is needed. What a surprise that I would say that. To build on these initial findings and support the development of different models of ACE Enquiry in different health settings. We would suggest some points for potential refinement of models of ACE Enquiry moving forward. Some of this involves sort of the process of design, including some more detailed assessments of readiness and the inclusion of patients in this decision-making process. Continued support and tools for monitoring. I think for me this is one of the key things. Obviously we're limited in understanding what's actually delivered on the ground, but providing services with a way to at least capture how they might deviate from agreed models and what their experiences of that are is really crucial, I think, for monitoring. Some challenges in terms of refining models in identifying how ACE data can be stored and shared. So I haven't gone into too much detail in this, but in the Wales GP pilots, the total ACE score was recorded but was hidden in EMIS somewhere under some random research participant code because they were quite concerned about how that information would be used and maybe accessed. But actually what that means is it's not clinically relevant for someone other than the clinician that delivered that questionnaire. So there's challenges there around, what's the most suitable model for how we store and understand the data. Obviously there's this sense that in some cases, if it's only certain individuals delivering, that it's not really an embedded model, and therefore there's limitations in how well that kind of reflects a wider cultural change. And I suppose there's a question mark around the entire service user pathway. So this process of asking about ACEs is one particular approach, but how is the wider pathway ACE informed to support individuals moving forward in terms of understanding that information? And the final thing really around implementation is models that extend to other population groups. So obviously a key interest in incorporating fathers or other caregivers in health visiting. But also there was a real sense actually among the GPs that we worked with that if a universal model of routine inquiry is really difficult, then where does it make sense for us to try and target this approach? Should it be with patients with chronic health conditions? Can it occur in new patient checks if we have those? Is there a way that we can look at a model that's more sustainable but perhaps acts as a subsection of our population. And then from a research perspective, just some of the things that I think are still the big unknowns that are important for us to challenge and consider are obviously understanding this inherent therapeutic benefit for patients, I think, or service users is a key thing for me. So can we find a way to kind of, in more detail, reflect with them on their experiences of ACE Enquiry and what that means for them? I think there's important considerations in how it affects their wider service use behaviour. If we create a culture when people expect their GP to ask them, do they then kind of feel less positive about their health visitor if their health visitor doesn't ask them? And there are implications there around wider service use. I think much more work is needed with practitioners to understand how they might use that information. So how does understanding ACEs affect the decisions that they make around patient support and care? And I think one of the biggest challenges for us is that still we don't really understand what we would expect to change. So do we think that patients with ACEs attend and engage with our services more because they are likely to have an increased need? Or actually do they generally attend less because they're less willing to engage in preventative approaches, or they have particular barriers to their engagement? And until we understand that, understanding the way in which service use changes as a result of ACE Enquiry is really, really difficult. So I think the other important reflection for me is that we saw some differences in secondary care referrals, for example, and it's about finding ways that we can look at the wider health system and beyond to understand these potential changes. So we might not expect to see a change in how often they engage with their GP as a result, but where else might we see that change? Could it be engagement in emergency medicine or other sectors entirely?